Welcome to our podcast on an introduction to anaesthesia. We're going to be taking you through the main stages of what a patient goes through when they have an anaesthetic. I think it's important that medical students and young doctors understand what happens when a patient undergoes surgery that needs anaesthesia. Anaesthesia is a drug-induced reversible loss of consciousness, and traditionally we think of it as having three parts: hypnosis, which is the unconsciousness element; analgesia, which is the pain relief element, which can be systemic analgesia or regional local analgesia; and neuromuscular relaxation or paralysis. Of course, each of these things has specific and different side effects, and that's one of the skills of the anaesthetist, to balance and treat these side effects. In the preoperative assessment unit, the patients meet a nurse or a doctor. Here, they have a history taken, they're examined, and appropriate investigations are performed. We always discuss with them the risk of surgery, the risk of anaesthesia, and any alternative treatments. We also encourage them to become involved, fully involved, and aware of what treatment options may be available to them, including not having surgery, which is called shared decision making. We also offer any suggestions as to what modifiable risk factors they may have, for example, losing weight, exercise, smoking, or continuing, stopping, or starting new drugs. One of the basic divisions of anaesthesia is between general or regional anaesthesia. The typical anaesthetic that we think of as an anaesthetic is a general anaesthetic. The patient's unconscious. But with a regional anaesthetic, which we can do in addition to a general anaesthetic, the patient need not be fully asleep. They can be sedated or even awake. The regional anaesthetic is great at reducing postoperative pain, but of course there may be specific side effects. For example, as nerves travel together, motor and sensory nerves, it may be that we will reduce the walking or the motor function of the patient in the immediate postoperative phase. Okay, so the patient has come to the day of surgery. They've arrived at the hospital and they've come to the anaesthetic room, which is what we see here. We've got pictured here a big stack of airway equipment, a skilled assistant, monitors, and the anaesthesia machine, which is the way of delivering a very controlled, precise amount of gas to the patient. Before anaesthesia or surgery can start, we have to do the WHO surgical safety checklist. This is a checklist designed to reduce wrong site surgery, encourage communication between all the members, including the patient, and to make sure there are no preventable errors that are about to take place. Once the WHO checklist has been done, we can move to the immediate phases of anaesthesia around the time of surgery: induction, maintenance, emergence, and recovery. Induction involves going to sleep, maintenance, of course, staying asleep, emergence, moving from that surgical state of sleepiness through to awakeness, and then recovery, getting back all your normal vital signs, including eating and drinking, speaking, your ability to control your own airway. At each stage of the process, we can think about it in terms of an ABCDE approach. What are we going to do about the airway, the breathing, the circulation, the drugs, and the environment of the patient, for example, temperature, skin, and eye care? Induction of anaesthesia can be done two basic ways. We can do it in terms of a standard intravenous induction, which is probably the most common way, certainly in the UK. We give an intravenous analgesic agent, usually fentanyl, which is a short-acting opioid, and then we give propofol, which is a hypnotic agent. We can also induce anaesthesia in a volatile or inhalational way. Here we'll give the patient oxygen and air, or oxygen and nitrous oxide, with sevoflurane. When we're thinking about a general anaesthetic, as I said, we think about the triad of anaesthetic drugs: hypnosis, analgesia, and neuromuscular relaxation. We give neuromuscular relaxation if intubation is required or if the surgery needs a still patient. This can be either a depolarizing, suxamethonium, or a non-depolarizing, also known as a competitive, such as atracurium, rocuronium, or vecuronium. The general anaesthetic agents and neuromuscular relaxation cause obtunding or loss of the airway. The solution to this is to provide an artificial airway device. Initially, though, we would do some airway manoeuvres, chin tilt, jaw thrust, and then we would add some adjuncts such as a Goodell airway or another supraglottic device such as a laryngeal mask airway. And we may even intubate the patient, that is, put a tube through the vocal cords into the trachea and blow up a cuffed oral endotracheal tube. We can maintain anaesthesia in one of two ways, in the same way as we can induce anaesthesia in two ways. We normally keep a patient unconscious with volatile drugs in oxygen and air, but we can continue an intravenous maintenance dose of propofol, usually with an intravenous opioid. Here we see a close-up of the anaesthetic machine, where the anaesthetist has dialed up some oxygen, some air, and some sevoflurane. There are several issues about the immediate perioperative care. Analgesia, or pain relief, reduces the sympathetic response, i.e. the heart rate rises, the blood pressure rises, and the respiratory rate rises if the patient's breathing spontaneously. Of course, analgesia is a humanitarian, a kind thing to do for a patient, and will allow smooth emergence and comfortable state in the recovery period. We think about analgesia in a normal way, so we think about simple, non-steroidal and opioid, either ladder of analgesia, and we may have regional or local analgesia as well. When the patient's asleep, we have to think about the correct positioning. We have to think about keeping the patient warm, because of course patients without clothes on, who aren't moving, receiving cold fluids, with body parts exposed, will become hypothermic. We also have to think about their fluid balance. There are lots of other things that we do around the time of surgery. Anaesthesia often induces hypotension, so we often have to give cardiovascularly acting drugs to offset or counteract the effects of the anaesthesia. These can comprise fluids, alpha, vasoconstricting, or beta, adrenoceptor agonists, and anti-muscarinic cholinergic drugs to increase the heart rate. We often give antibiotics to reduce infection, and we may need to give blood and blood product transfusions. When we're thinking about the post-operative phase, we need to consider what's happening with the patient's normal drugs, of course. What are we going to do about the analgesia, antibiotics, and DVT prophylaxis? As the operation nears its end, we need to think about waking the patient up, of course. We need to make sure that they've had analgesia, they've had antiemetics, and that neuromuscular function is restored by reversing the effects of paralysis. When we've shown that they have spontaneous neuromuscular function, I can move, we switch off the maintenance general anaesthetic agents, be it propofol or the volatile agents. If the patient has an airway device in, for example, endotracheal tube or a laryngeal mask, when they wake up, we will take that out. Of course, there may be immediate post-operative complications that we will monitor for. The patient then moves to the recovery area where they're very closely monitored. All the normal monitoring such as heart rate, blood pressure, rhythm, non-invasive pressure, saturation and breathing are recorded by recovery nurses. Of course, again, we can think about ABCD. We have to think and make sure that the airway is open, the patient's breathing, the circulation is in a good state, and that we're giving appropriate drugs. We'll give at this point extra pain relief should the patient require it. Of course, the patient's journey does not end there. Many patients will go from recovery to the ward or from recovery to the daycare unit where they'll leave hospital that same day. Some patients, however, will go to the intensive care unit where they'll have extra treatment and extra monitoring. When patients are back on the ward or in ICU, we have to think of a variety of things, but we'll certainly be thinking of analgesia, pain relief, making sure their cardiovascular state and breathing is good. And we will also involve them in this concept of an enhanced recovery program from surgery. Thanks for listening to our podcast. We've talked about the immediate journey that the patient takes just before, during and after surgery. Don't forget, if you want to find out more, do come to theatre with us. Do look at any of the articles on the UCL Student Anaesthesia website, or look at some of the podcasts. Thanks so much.